Pharmacotherapy of migraine. So the main objective for this session is you should be able to define migraine, describe the pathophysiology, describe the acute treatment of migraine, non-specific and specific treatment, preventive treatment of migraine, and describe in brief the newer targets and the drugs. Now this is the second most common type of primary headache. So which is the most common type? सबसे common क्या है headache में? Yes. सबसे common headache कौन से type का headache है? What are the various types of headache? कौन बताएगा? See, the tension headache is the most common type of headache which is related to stress and all. So that tension headache is the most common type, and then comes this migraine. Now this is a chronic neurological disorder. Migraine is a chronic neurological disorder and it is characterized by episodic attacks of headache and associated symptoms. So later on you will see what are the symptoms of migraine, and it is more prevalent in females as compared to males. And the brain of the migraine is particularly sensitive to environmental and sensory stimuli. So there are various triggers for migraine. It could be food, it could be drug related, it could be environmental related, hormones related, or it could be due to intake of some alcohol or something that may also trigger migraine. Now the pathophysiology क्या है migraine के behind? The three theories was given. That is, the first was the vascular theory. Now it attributes to the phenomena of vasodilation. ठीक है, सबसे पहले it was said that there is a vasoconstriction and it really causes the shunting of the carotid AV anastomosis, shunting of the blood, and it may result in cerebral ischemia, which may result in then reactive vasodilation. So that was the vascular theory. So vasodilation was the cause behind the migraine, not the vasoconstriction, because the drugs which is found to constrict the vessels was found to be effective in migraine. ठीक है, जो वैसो कॉन्स्ट्रिक्शन कर रही है सेरिब्रल वेसल्स का वो इफेक्टिव है माइग्रेन में, एंड द पैथोफिजियोलॉजी इज वेसोडाइलेशन. ठीक है, देन कम्स दैट नॉट ओनली द वेसोडाइलेशन इज इन्वॉल्व, देयर आर द अदर न्यूरोजेनिक थ्योरी वाज आल्सो गिवन दैट देयर इज अ स्प्रेड ऑफ there's a cortical spreading depression, that is the electrical activity is spread in the brain, which may result in aura, and then it may result in vasodilation, and then which may result in migraine headache. Okay. And the third theory, that is the theory is that there is neuro and vascular involvement. So what exactly happens is, so vasoconstriction and ischemia which accounts for the migraine aura, and there is reactive vasodilation, that was the vascular theory. And now there is this cortical spreading depression. Now this spreading of depression, cortical spreading of depression, is because of the NMDA receptors. ठीक है, they are saying that these NMDA receptors are hyperactive, which may cause the spreading of these cortical spreading depression, and this electrical activity will cause the vascular membrane inflammation, which in turn may leads to the retrograde stimulation of the nerves, afferent nerves, which may release the inflammatory mediators. So these will release the inflammatory mediators like CGRP, 5-HT, neurokinin, substance P, nitric oxide. Now these inflammatory mediators will cause the leakage of the fluid, and it will causes the perivascular edema and stimulation of the nerves like trigeminal ganglion, trigeminal nucleus, or trigeminal cervical complex. Now this nerves or neurons, when get stimulated, it may cause the pain stimuli which may result in headache. ठीक है, तो सबसे पहले क्या हो रहा है कि there is spread of these electrical activity which may result in the inflammation of the cerebral vessels, which causes the retrograde efferent nerve stimulation, which may causes the further release of these inflammatory mediators. So there is neurogenic inflammation occurring, and the most important which is causing the neurogenic inflammation is the CGRP protein. Okay, CGRP protein has an important role in the pathophysiology of migraine. Now this with serotonin, because serotonin receptor will cause the increase in release of the CGRP protein. Okay, it causes the degranulation and it causes the release of CGRP protein. So this CGRP protein is for causing this cerebral vessel inflammation and then the perivascular edema and then nociception. Okay, the migraine headache. So you can see here in the picture, there is this neural activation, there is degranulation, CGRP degranulation, and this CGRP will act on its receptors which are there present on the membrane of the cerebral vessels, the meningeal vessels, and this causes the vasodilation. CGRP क्या कर रहा है? Vasodilation of these vessels. Now when there is vasodilation occurs, there is leakage of the fluid which causes perivascular edema, and it will causes the stimulation of the nerves which is resulting in the pain stimuli which may cause the migraine headache. So these neurons, they get active, they are releasing these inflammatory mediators. These inflammatory mediators, the main is CGRP. CGRP will act on its receptor present on these cerebral vessels, and these cerebral vessels, when they causes vasodilation, this will causes the perivascular edema, and they causes the nociception. Now how you will diagnose a migraine? कि ये migraine का headache है. So migraine is of two types, with aura or without aura. Now this without aura, this is the most common type of migraine compared to the aura, with aura. So at least 5 attacks fulfilling the criteria B to D, you will diagnose it as migraine headache. So headache which is lasting for 4 to 72 hours, which is untreated or unsuccessfully treated. तो इतना duration का अगर headache है और at least 2 symptoms हैं, unilateral location, pulsating quality, moderate or severe pain intensity, aggravation by or causing avoidance of routine physical activity. ठीक है, so this is the classical symptoms of migraine. It is unilateral pulsating headache, moderate or severe pain intensity, and it is aggravated by or causing avoidance of routine physical activity. Now during headache, at least one of the following is present. Either nausea or vomiting will be present, or photophobia or phonophobia will be present, and it is not attributed to any other disorder. Then you classify it as migraine without aura. Now there is another one is with aura. अब ये कैसे classify करोगे? 2 attacks, at least 2 attacks and fulfilling B to D criteria. तो B2D क्राइटेरिया में क्या है कि उसके पास उसको ऑरा में क्या हो, कोई विजुअल सिम्टम्स. Visual symptoms can be positive, can be negative. Positive symptoms like flickering lights, spots दिख रहे हैं उसे, lines दिख रही हैं, और negative में loss of vision हो रहा है. ठीक है, so any of this or reversible sensory symptoms can be positive, can be negative. Pin or needle sensation, or negative is numbness will be there, or it is fully reversible dysphasic speech disturbance. ठीक है, तो any of this symptom or at least two of these symptoms like visual symptoms or unilateral sensory symptoms, at least one aura symptom, and this may last for 5 to 60 minutes. Now headache which is fulfilling B2D criteria of migraine without aura will also be there with this aura symptoms. Then you classify it as migraine with aura, and it is not attributed to any other disorder. So these are the two types of migraine. Most common is migraine without aura. There is an acute abortive treatment and preventive or prophylaxis treatment of migraine. Based on the severity of the migraine, you will treat the migraine. ठीक है, जब भी हम क्लासिफाई करेंगे फार्माकोथेरेपी ऑफ माइग्रेन, सो इट इज बेस्ड ऑन द सिवियरिटी ऑफ द माइग्रेन. So you have this is the pharmacological treatment, and then there is non-pharmacological treatment is there, which is always you have to recommend that you have to avoid the triggers. ठीक है, you have to tell the patient that notice all the triggers, maintain a diary. ठीक है, and avoid the triggers, and the lifestyle relaxation measures has to be advised, and then comes the pharmacological treatment, that is acute abortive treatment and prophylactic treatment. So based on the severity, mild कब कहेंगे, जब less than 1 attack per month and it is lasting to up to 8 hours. Duration and the frequency के basis पे हम severity classify कर रहे हैं headache की. तो एक लेस देन 1 अगर एपिसोड है पर मंथ तो माइल्ड है. अप टू 1 यू विल क्लासिफाई, 1 अगर एपिसोड पर मंथ हो रहा है तो देन इट कम्स टू मॉडरेट कैटेगरी विथ नॉजिया और वॉमिटिंग. 6 to 24 आवर्स का अगर वो हेडेक का ड्यूरेशन लास्ट कर रहा है देन इट इज मॉडरेट. एंड इफ इट इज 2 or 3 episodes or more then it is severe migraine. Now this requires a prophylactic treatment and it goes for 12 to 48 hours. So severe migraine requires a prophylactic therapy. So how this is treated? Mild moderate you have to give simple analgesics. Simple analgesics में क्या आएंगे? Paracetamol. So what is the dose of paracetamol? So 500 to 650 milligram. Normally it is available as an adult dose of paracetamol. So you can give. Now when you have to give is at the start of the symptom. ठीक है, in the beginning as early as possible the drug therapy has to be started. Then it is effective. Then it is more effective compared to if it has been delayed. So simple analgesics or NSAIDs or their combination can be given. ठीक है, तो खाली simple analgesics में paracetamol you can give or NSAIDs, ibuprofen, naproxen, etc. You have NSAIDs or their combination paracetamol with ibuprofen combination. So their combination can be given with or without antiemetic in mild cases of migraine. Moderate migraine, NSAIDs combinations are usually given, or a triptan or an ergot alkaloid with an antiemetic is to be given in moderate case. ठीक है, यहाँ पे आप स्पेसिफिक थेरेपी एंड नॉन स्पेसिफिक थेरेपी दोनों दे सकते हो. स्पेसिफिक में आपके ट्रिप्टन्स और अर्गॉट आते हैं स्पेसिफिक थेरेपी, और नॉन स्पेसिफिक थेरेपी में यू हैव दीज एंटीमेटिक्स, यू हैव NSAIDs, दीज एनाल्जेसिक्स, दे कम इन नॉन स्पेसिफिक. Severe migraine, you have to give specific therapy, that is triptans has to be given or ergot alkaloids with an antiemetic with prophylaxis. So in prophylaxis, the most commonly used or the most preferred prophylaxis is propranolol or the other beta blockers. The propranolol is the prototype drug which is to be given in as a prophylaxis in migraine, and uska kab aata hai effect? 2 to 4 weeks. So at least 4 weeks he has to take the propranolol around 40 milligram to, it can extend to 160 milligram, and it has to be continued till 6 months, and then based on the frequency you have to reduce. So you can increase the dose from 40 milligram OD to BD to 160 milligram maximum limit of the propranolol, and then it has to be given till 6 months the prophylaxis, and then you can discontinue according to the stage of the according to the frequency of the migraine. Then you have this amitriptyline or other tricyclic antidepressants. Now they are more preferred in the patients who have a depression associated with migraine. Then you can prefer these antidepressants like amitriptyline. Then flunarizine or other calcium channel blocker, this is also effective, flunarizine. Valproate or topiramate, these are the anticonvulsants which can also be given as a second line prophylactic therapy. So first line prophylactic therapy mein you have this beta blocker comes in first line prophylactic therapy of migraine. Now coming to the non-specific, NSAIDs kya kar rahe hain? NSAIDs, now these prostaglandins E2 and I2, ये जो prostaglandins release हो रहे हैं, these triggers may release these prostaglandins and they reduce the threshold to stimulation of nociceptors and causing peripheral sensitization. Now CGRP release from the terminals of the trigeminal sensory neurons is modulated by again prostaglandins. So it stimulates the release of CGRP protein. So it blocks the NSAIDs blocks this COX enzyme release of the prostaglandins. COX enzyme को ब्लॉक करके प्रोस्टाग्लैंडिन की रिलीज को इनहिबिट करते हैं NSAIDs. So ibuprofen, naproxen, diclofenac, mefenamic acid, indomethacin, etc. These are the drugs which are used as NSAIDs in migraine. Okay, so ibuprofen, the dose is 400 to 800 milligram. Ibuprofen, this is the NSAID which can be used in migraine. Now antiemetics you have, क्योंकि migraine में क्या हो रहा है? Migraine में there is decrease in gastric motility, gastric stasis is also there. So you have to use, there is nausea and vomiting symptoms. To decrease that, you can give metoclopramide, is an antiemetic drug, 10 milligram of metoclopramide, or you have the other antiemetics like domperidone, prochlorperazine, diphenhydramine, or promethazine. So this can be given with caffeine. Caffeine के साथ combination में आते हैं ये. Caffeine का क्या फायदा है? It blocks the adenosine receptor and has a vasoconstricting action. ठीक है, कैफीन फायदा करती है माइग्रेन में by causing the vasoconstriction. And sometimes you need to use the sedative drugs like codeine, diazepam, etc., which can be combined as a non-specific therapy in migraine. ठीक है, तो ये सारी हमारी non-specific therapy हो गई migraine की. Simple analgesics, NSAIDs like ibuprofen, naproxen you have seen, and then you have antiemetics and sedatives. Specific treatment in acute attack of migraines, वो भी acute attack में दे रहे हैं हम NSAIDs भी. You cannot use prolonged therapy of NSAIDs. ठीक है, इसको हमें acute attack में use करना है NSAIDs को. Again in acute treatment you have triptans. This is a specific therapy for migraine and more effective therapy compared to ergotamine, more preferred therapy compared to ergotamine or ergot alkaloids. So in the triptans you have sumatriptan, naratriptan, rizatriptan, alitriptan, zolmitriptan, almotriptan, frovatriptan. Shortest duration of action is sumatriptan ka. Frovatriptan has the longest duration but it is slower in onset. Rizatriptan has a faster onset and longer acting. Now what is the mechanism? They are selective for 5-HT1B 1D agonist. 1D receptor के selective action है. They are 5-HT1B 1D agonist. So remember what are the mechanism of triptans? 5-HT1B 1D agonist. तो ये क्या कर रहे हैं? ये रिसेप्टर पे एक्ट करके it causes the vasoconstriction and it decreases the release of CGRP. So both the effects it is having, it causes a vasoconstriction by acting on this receptor and it decreases the release of CGRP. So these are the serotonin receptor you can see here. This is the serotonin in the black. This is the serotonin receptors. These are the serotonin receptors. So by acting on these receptors, it causing the vasoconstriction and it is also causing decrease in the degranulation and release of CGRP protein. So it decreases the plasma protein extravasation. So it prevents the peripheral release of these vasoactive peptides and reduces the plasma protein extravasation. तो ये जो plasma protein extra जो बाहर जाता है, that is causing the perivascular edema and stimulation of the pain neurons, that will be decreased. Sumatriptan है जो कि oral bioavailability is only 15%. So it can be given subcutaneously as an injection and elimination half-life is very short, that is 2 hours. So it is the shortest acting sumatriptan. So what are the adverse effects now? Most important is coronary artery vasospasm. ठीक है, vasoconstrictor है, you have to be very careful. It can cause coronary artery vasospasm, transient myocardial ischemia, arterial and ventricular arrhythmia and myocardial infarction. Irritation at the site of injection, and the most common side effect of sumatriptan nasal spray is a bitter taste. So it can also be given by nasal spray. Sumatriptan can be given parenterally, it can be given by nasal spray, it can be given orally also, but the bioavailability is very less oral when you're giving sumatriptan. So, and it is contraindicated thereby in coronary artery disease, who have the history of stroke, transient ischemic attacks, hypertension, cerebrovascular or perivascular disease. In all these conditions, sumatriptan is contraindicated. So now we have ergot alkaloids. Ergot alkaloids का mechanism क्या है? They are partial agonists and antagonists at serotonergic, dopaminergic and adrenergic receptors. ठीक है, ये partial agonistic and antagonistic effects you must have. This must be taken for you. Ergot alkaloids. So they are the partial agonists and antagonists at all these 3 receptors: serotonergic, dopaminergic and adrenergic. इसका एंटी माइग्रेन इफेक्ट कैसे आता है? एंटी माइग्रेन इफेक्ट इज बिकॉज दे आर ऑल्सो अगोनिस्टिक एट 5-HT1B1D रिसेप्टर. ठीक है, दे आर एक्टिंग एज एन अगोनिस्ट एट द 5-HT1B1D receptor, and therefore their acute migraine effect is mainly due to this. So you have 2-ergotamine and dihydroergotamine. Ergotamine is always given orally, not parenterally. Dihydroergotamine can be given parenterally also. कैफीन के साथ अगर आप देते हो तो इट विल इनहेंस द एब्जॉर्प्शन ऑफ अर्गोट एल्कलॉइड्स बोथ बाय ओरल और रेक्टल रूट. कौन से पेशेंट्स के लिए फिर हम अर्गोट देंगे? हम प्रिफर ट्रिप्टन्स करते हैं बिकॉज अर्गोट हैज लॉट ऑफ साइड इफेक्ट्स. So which patients you can prefer ergot? Patient who's require migraine specific therapy and who are already established on ergotamine, जो already ergotamine पे हैं और उनको सूट कर रही है, you can continue ergotamine. You need not have to change. And in special cases, patients with very long attacks or with frequent headache recurrences are there, where triptan is failed, then you can use ergot alkaloids. Now what are the adverse effects? Nausea and vomiting. Usually nausea and vomiting is more in these patients. It can also trigger nausea and vomiting. अगर आप ergot alkaloid दे रहे हो, it may trigger nausea and vomiting due to direct effect on CNS emetic center. That is the main side effect. Triptans का क्या था main? Coronary artery spasms. यहाँ पे है nausea and vomiting. And it is contraindicated in pregnancy, peripheral vascular disease. It also causes vasoconstriction, so it is contraindicated in these conditions: coronary artery disease, hypertension, impaired hepatic and renal functions. तो ये सारी हिस्ट्री लेनी है, then only you have to prescribe ergot alkaloids. Coming to the preventive treatment of migraine. Now why we give prophylaxis and when we give prophylaxis? Why we give prophylaxis? Yes, to reduce the frequency. It does not cure. Remember this, prophylaxis will not cure migraine, but it reduces the frequency, duration and severity of the migraine attack. It improves the responsiveness of acute therapy. ठीक है, these are the two main things which this prophylactic therapy is doing, reducing the severity, duration and the frequency of migraine attack, and also it is increasing the responsiveness of acute therapy. Ergot alkaloids compared to triptan is less costlier compared to triptan, but it has more of this side effects. Vasoconstricting, nausea and vomiting side effects will be more compared to triptans. So prophylaxis, 2 or more attacks कब हम देते हैं? 2 or more attacks per month that significantly interfere with the patient daily routine activity, an unsatisfactory response to acute therapy, contraindication to acute treatment and adverse effects related to them, an uncommon migraine condition including hemiplegic migraine or with prolonged aura or with migrainous infarction is there, then you have to use prophylactic therapy. It is must to use prophylactic therapy in these conditions. क्या इनका mechanism होता है? In the prophylactic therapy, what is the mechanism of these prophylactic therapy? क्या है हमारे पास drugs prophylactic therapy में? Propranolol, we have antidepressants, amitriptyline, tricyclic antidepressant, we have calcium channel blockers, flunarizine, we have anticonvulsants like valproate, lamotrigine, and There are certain cases, ACE inhibitors like candesartan has also shown to be effective as a prophylactic, and botulinum toxin is also given in case of severe migraine attack. So it can be given, botulinum toxin can also be given as a prophylactic. So every 12 weeks, one injection of botulinum toxin is given in the head and neck in case of very severe migraine. So what they do, this prophylactic therapy is, they raise the threshold to migraine activation by stabilizing a more reactive nervous system. It enhances the anti-nociception, inhibits the cortical spread of depression, inhibit the peripheral or central sensitization, and block the neurogenic inflammation. Okay? Neurogenic inflammation is also blocked by these prophylactic therapy. So कब तक देनी होती है prophylactic therapy? असर कब तक आता है? So at least 1 month therapy will be, you have to give to see the effect of these prophylactic therapy, and it has to be continued till 6 months. Okay? And then you have to decide based on the severity of the migraine. So that is all with the migraines. So based on the severity of the migraine, you have mild, moderate and severe migraine. In mild migraine you have simple analgesic or NSAIDs, or with combination with or without antiemetic. ठीक है? Moderate NSAID combination or triptan or ergot alkaloid with antiemetic. ठीक है? Current status of ergot alkaloid is that it has to be used in case of severe migraine and resistant cases. This is the current status for ergot alkaloids. And in severe migraine, you also have to use specific therapy, that is specific therapy, triptan और ergot आते हैं हमारे specific therapy में, और उसमें आपको क्या use करना है? Prophylactic therapy also you have to start. कब कहेंगे severe है migraine? So 2 episodes या 2 से ज़्यादा episodes हैं, then it is a severe migraine. Now select the correct statement in relation to drug therapy of migraine. Simple analgesics like paracetamol are ineffective in migraine. Ergot alkaloids are used for prophylaxis as well as treatment of migraine. Use of ergot alkaloids is restricted to severe or resistant cases. Yes, ergot alkaloid should be given till 24 hours after an attack has subsided. No, it is not to be continued. Every half an hour, 1 milligram you have to give up to 6 milligram to control the attack. Not more than that you have to give ergot alkaloids. Prophylactic therapy of migraine is recommended in all cases. Is it recommended in all cases? No, it is not recommended in all cases of migraine. Benefit up to 70% patient of moderate to severe migraine. Yes, it benefits up to 70% patients of moderate to severe migraine. Needs to be continued lifelong without interruption? No, it need not have to be continued till lifelong. Reduce the severity but increases the frequency of migraine attack? No, it also reduces the frequency and the severity of the migraine. Ergotamine relieves migraine by blocking the vascular alpha-adrenergic receptor, blocking vascular 5-HT2 receptor, dilating cranial AV shunt channels or constricting cranial vessels, and reducing perivascular neurogenic inflammation. D is the answer. It constricts the cranial vessels. Main effect is by 1B1D receptor and reduces the perivascular neurogenic inflammation. The most important risk in the use of sumatriptan for treatment of migraine is coronary vasospasm. Now, a brief on the newer targets and the drugs. There are the newer drug therapy which has come up in migraine. 5-HT1F agonist. ये 5-HT1F agonist जो है, it does not have any direct vasoconstricting effect. ट्रिप्टन से अगर हम कंपेयर करें तो उसमें डायरेक्ट वैसोकॉन्स्ट्रिक्टिंग इफेक्ट है, इसीलिए इट इज कॉन्ट्राइंडिकेटेड इन सर्टेन कंडीशंस, बट 1F इज नॉट कॉन्ट्राइंडिकेटेड इन दोज कंडीशन, बट इट डिक्रीजेज द रिलीज ऑफ CGRP पेप्टाइड्स. ठीक है, ये जो इन्फ्लेमेटरी पेप्टाइड है CGRP, उसकी रिलीज को इनहिबिट कर देती है 5-HT1F agonist. D10s are the one. Lasmi D10 is in the FDA approved, which is a newer drug launched for migraine. Then CGRP antagonist. ठीक है, CGRP antagonist, you have G-pens which act on the CGRP receptor. They antagonize the CGRP action. They are rimegepant, ubrogepant. And then you have these monoclonal antibodies which are also being come up. They are acting on the CGRP receptors, these monoclonal antibodies, that is erinumab. These monoclonal antibodies can also be used for prophylaxis. So subcutaneously once a month, if you give this monoclonal antibody injection, they can also be used for prophylaxis, not for acute treatment only, but also for prophylaxis. ठीक है, तो monoclonal antibody CGRP, it is also used for prophylaxis, but it is very costly therapy. This is where you see the CGRP role. See, migraine triggers, now they causes initial vasodilation due to increase in nitric oxide activity and nitric oxide production. It is said that this is also release. ठीक है, क्योंकि आप अगर ग्लिसरॉल ट्राइनाइट्रेट अगर लेता है पेशेंट, that may trigger migraine attack. It is shown that they have triggered migraine attack because of this nitric oxide activity, because it causes vasodilation, and this initial vasodilation, they will stimulate the trigeminal nerve ending, that is the retrograde afferent nerve, that is the trigeminal nerve will get stimulated, which is present over the blood vessels, and it releases this inflammatory mediators, that is CGRP. Now this CGRP क्या करेगा, ये meningeal mast cell पे act करके it causes the degranulation and release of inflammatory agents, and this will causes the meningeal blood vessel, this meningeal blood vessels पे it causes the vasodilation. ठीक है, ये मास्ट सेल रिलीज करते हैं inflammatory agents in the meningeal vessels, and this meningeal vessels will get dilate and then will stimulate. Another thing is cerebral artery smooth muscle. Cerebral artery smooth muscle, it will causes increase in the blood flow. Then there is post-junctional sites, secondary order neurons will get stimulated, and painful impulse transmission. So this is all the role of CGRP. Neurogenic inflammation, increased blood flow, and painful impulse transmission. So CGRP is the target which has come up that has to be targeted to treat the migraine. So you have these antagonists which have come up, G-pens which are used, and you have this monoclonal antibodies, erinumab, which has come up, which is also being used as a prophylactic treatment in migraine. But these are very costly, and it is some are not even available in India. Then you have the another target is nitric oxide synthase inhibitor. Okay, because this nitric oxide is shown to cause the vasodilation and activation of these trigeminal neurons. So this is the target, but again the drug therapy has to come on this target. So you have this G-pen CGRP receptor antagonists in the trial, G-pen CGRP receptor antagonists, olicizepam, D10s 5-HT1F receptor agonist. This has been recently approved. And then tizamipine, that is the AMP and kainate receptor antagonist. So this is the another these NMDA receptors, AMPA and kainate receptor, which spread the cortical depression. That is again a target, and the drug trials are going on that it can have an effect on the migraine. This is just a brief on the newer therapy of migraine. So there is this case, let's discuss this case. A 36-year-old lady which is present with complaints of episodes of unilateral pulsatile headache for the past 2 years or so. Now during the initial episode, the headache was mild, was relieved by paracetamol or ibuprofen tablet. Now and did not interfere with her daily activity. However, the severity and frequency of pain episode has progressively increased, so that now episodes recur nearly every 1 to 2 weeks, especially at the beginning of her periods. Headache is preceded by lethargy, anorexia, nausea, and is accompanied by blurred vision, flashes of light seen on closing the eyes, unsteadiness, and frequent vomiting. The pain lasts for 12 to 18 hours, and she is incapacitated for nearly 24 hours. Now, the headache is not relieved now by over-the-counter analgesics or combination analgesics. So, what medication can be prescribed to treat the headache episodes? So, which category में आएगा ये migraine? Moderate to severe category, because every 1 to 2 weeks. So, it is around 2 episodes per month with aura. So usually अगर migraine है with aura, that was without aura हमने discuss किया अभी. Usually with aura वाले migraine you need to treat them with the specific therapy. ठीक है, analgesics may not work more in case of or not work much in case of migraine with aura. ठीक है, उसमें ज़्यादा इफेक्टिव है स्पेसिफिक थेरेपी. बट इन्होंने स्टार्ट किया है बेस्ड एंड देन इट इज प्रोग्रेस टू नाउ टू सिवियर, मॉडरेट टू सिवियर कैटेगरी में आ गई अब. सो व्हाट आर द मेडिकेशन यू हैव? तो एक्यूट ट्रीटमेंट के लिए व्हाट यू विल प्रिफर? ट्रिप्टन्स. सो आप यहाँ पे ट्रिप्टन दोगे. यू हैव सुमाट्रिप्टन, रिजाट्रिप्टन. सो यू विल गिव दीज ट्रिप्टन ड्रग्स, बट यू हैव टू बी केयरफुल दैट now 50 to 100 milligram dose of sumatriptan is available as oral medication. So you can start with the dose of sumatriptan, and you can see and can repeat it if there is another attack after 8 hours, but don't give more than 2 or 3 tablets. ठीक है, for an attack don't use triptan more than 2 or 3 tablets. ठीक है, उससे ज़्यादा आपको नहीं. Tell the patient to not use. Overusing of these tablets can also cause rebound headache. ठीक है, अगर overuse आप करेंगे इन tablets का, they may cause rebound headache. This specific treatment may cause rebound headache if you are using it more. So what specific medical history need to be elicited? Now you are using the specific therapy. So what specific medical history need to be elicited? क्या contraindications हैं that you need to keep in mind? Now you have to take that history. Heart का patient नहीं है, then hypertension हो गया, renal and liver functions, pregnancy. You have to see all this. So BP आप note करोगे physical examination में. You will do all this investigation and then you will prescribe the above medication. Apart from treatment of pain episode, can this patient be put on some regular medication to prevent or minimize the episodes? Yes, you can start the prophylactic therapy. More preferable is propranolol. So you can put the patient on propranolol prophylactic therapy as 40 milligram once or twice a day. Okay, to start with, you can start the propranolol once or twice a day.